With those preliminaries, Dr. Seshamani, it's so great to have you back for another Policy Spotlight, and welcome also to a Health Podyssey.
It's great to be back. Thanks for having me, Alan.
So, Meena, you and I have worked together enough. I hope I can call you Meena.
Yes.
When you came on before, you were talking about your agenda, and here we are, deep into it. Just to provide a little structure to our conversation, tell me what you view as your top priorities, and we'll start working through some of them, and I'll dig a little deeper as we go.
Yeah, absolutely. Well, Alan, building off of our last conversation, Medicare really plays a critical role in driving change in our healthcare system, right? As the largest payer, almost $1 trillion in claims, partnering with 1 million clinicians, 6,000 hospitals. So, really our agenda has been how we can leverage Medicare and utilize the Medicare program to really drive change, not only for the 64 million people who rely on the Medicare program, but also what, path that sets for the broader system. Thinking about how we can advance health equity such that everyone has a fair and just opportunity to obtain their optimal health, regardless of the various characteristics that come into play in influencing someone's health or their ability to access healthcare. How we can expand access to coverage and care, driving innovation for high quality, whole person care, and being good stewards of the Medicare program. And you mentioned, in your intro, kind of 3 big areas in which we are driving change: Medicare Advantage, implementation of the new prescription drug law, the Inflation Reduction Act, and all the work we're doing in transforming care through our value-based care initiatives, and also through our, underlying traditional Medicare program as well. So I'm sure we can dive into any and all of that.
Well, let's do exactly that. So I think it's good to take them in the order that you mentioned. I guess I kicked it off that way. Medicare Advantage, it's half the program now. And I don't think even its biggest boosters at the time, and of course they're precursors to MA, but I don't think we ever thought we'd get to this point. And so it becomes important in its own right. And just as you said that Medicare is a tool, an opportunity to affect the entire healthcare system, the play between MA and traditional Medicare also there's a mutually reinforcing and as well as sort of a competitive element to them. So why don't we start, if you could just tell me what's top of your mind on MA, and then I'll probably ask you a few questions about the items on my mind.
Yeah, absolutely. And, piggybacking off of what you said, Alan, Medicare Advantage plays a very important role in the Medicare program, right? When I think about the Medicare program, there is Medicare Part A and B for traditional fee-for-service Medicare. There's Part C, Medicare Advantage, Part D, prescription drug coverage, and then the Medigap and supplemental policies. And, my goal is to make sure that we have a robust set of options that are all geared towards serving the person with Medicare, driving the kind of vision, the collective vision that we all have. And so to that end, last year, we put out a request for information in the Medicare Advantage program. The first time that we put out there and said, hey, we want to discuss what's working, what isn't, and really engaging everybody who's involved in this space. So health plans, providers, patient groups, employers, academics, and we got more than 4,000 comments from that request for information. And those comments and that feedback that we got really has formed the foundation of some of the policymaking that we've been doing. Again, driving towards those pillars. So, for example, where we now have for health equity, have created a health equity index in the Medicare Advantage program under the star ratings, so that health plans that are caring for underserved populations, if they meet the quality metrics, they can be eligible for additional reward, in line with what we're doing elsewhere in fee-for-service as well, so that we can reward excellent care for underserved populations. We heard a lot about the confusion that's been created with potentially misleading marketing practices. That's something that we heard from absolutely every single, group out there. And so we proposed and finalized policies to rein in misleading marketing practices, saying you can't use the Medicare logo in a misleading way. You have to say which health plans you are representing, and other, policies like that. We also heard from many different groups about prior authorization, where plans wanted to have clearer rules of the road of what kinds of utilization management they can do. Providers commented on the incredible burden that some of the prior authorization was creating, and patients expressed that they felt they couldn't get access to medically necessary care. So we also put out policies saying, look, the prior authorizations must follow traditional Medicare national coverage decisions or local coverage decisions. Where there isn't one, then you have to follow publicly available, widespread clinical evidence and have, regular yearly updates and review of the clinical protocols, again, to try to make sure that all of what's happening in Medicare Advantage is really serving the people that we intend to serve. So those are just, a few examples from our rule. And then, we heard a lot about payments and the importance of payment accuracy. So in the latest rate announcement, we had finalized to update the data years from using 2014 to 2019 in the risk adjustment model, to update the diagnostic nomenclature, to move from ICD-9 to ICD-10, and then also to take a look at what the coding patterns are between Medicare Advantage and fee-for-service, to really utilize those codes that are associated with incremental costs of treatment so that payments can be more accurate. And those are changes to the risk adjustment model that are getting phased in, over the next 3 years. Again, and that really comes to, how do we improve equity? How do we improve quality? How do we make sure people have good choices so they can get the care they need? And how do we make sure we're being good stewards of the program?
So I really